Much, Dr. Goel, and thank you very much for inviting me to take part in this excellent symposium. You can see my slide now, I hope. So I've been invited to speak about bilateral cataract surgery in a number of places now. It seems to be becoming the new normal after COVID. So I tried to change to give you a bit different talk, and hopefully you'll appreciate it. Of course, I have no conflicts. Doesn't matter which eye you do. If you do one or two, it's all the same thing, whoever you consult for. Due to COVID-19 restrictions, everybody suddenly wants to do bilateral cataract surgery. It almost doubles the number of cases you can do per day when you have to clean your operating room and ventilate it for a while. And so dollars and time have become big issues in ophthalmology, which I'd like to mention. I don't know about in India because many of you are in private practice, but in North America, it's a big difference. So I was the first to study cost and reimbursement of bilateral surgery because I was one of the first in the world to do it. And I was being exposed to prejudice and issues about why we do bilateral surgery. So we wrote a number of papers. And then my summary of this is that, it's appropriate to study comparative costing and reimbursement of doing bilateral surgery or unilateral surgery twice in different jurisdictions. I think it's not appropriate and perhaps unethical for us to choose to do unilateral or bilateral surgery because one pays us better than the other. But it is appropriate to lobby jurisdictions to fund surgery equally. So whether you choose to do bilateral or unilateral surgery based upon the specific case, you're funded fairly. So that's the brief summary of the finances. Now, so the next question comes up is, when should one consider embarking upon bilateral cataract surgery? Well, the summary briefly is when you have an extremely low complication rate. Once every step of your procedure has been perfected and you know how to dilate pupils intraoperatively as well as preoperatively, you can deal with small pupils. You understand OVDs, how to use different ones in different situations. You understand phaco machines and how you can set them better, perhaps in different situations. You're competent with IA, doing very well. Your biometry and your IOL selection implantation are all accurate, so you're not replacing lenses. You use intracameral antibiotics always, and you're good at it, and you make sure that you seal the incisions, and your surgery is more or less complication-free, and you have a routine of postoperative drops and follow-up that works very well. Unless you have all of those things worked out well for one eye, you probably shouldn't do two. So the next question is, well, if that's the case, why then do you perform bilateral surgery? And the answer simply is, for all of us who do it, it's better for the patient and it's better for everybody else who's concerned. So I think I was the first in the world to publish a relatively large case of 1,020 consecutive bilateral surgery patients completed in 2002. And we had an extremely low complication rate, and so we were quite happy to publish it. And then just after our publication, we found that, well, we weren't the only ones in the world. The Finns were probably first as a country because they were adopting completely elective by patient choice bilateral cataract surgery since about 2002. Sweden was looking at doing bilateral surgery in 2003, and Bjorn Johansson published a smaller series than mine, roughly the same time as ours. And in Spain, the group on the Canary Islands was approaching the government to try to submit a study to the government so they would approve bilateral surgery as being equally safe and effective as unilateral surgery. And it's the only country in the world where an act of parliament eventually reviewed the study and decided that bilateral surgery was equally safe and effective as unilateral surgery. So my background is that I've been doing routine bilateral surgery by patient election since 1996, probably the first in the world to do them electively. And I've done about 12,000 eyes by now, and 80% of my surgeries now are bilateral surgeries. One of the things I think is very important, I use intracameral antibiotics in every case. I initially used vancomycin that I learned from Gimbel and Gills, but we stopped using that in 2003 because the government told us we had to use a generic version, which was made in Toronto and was very cheap, but unfortunately it always caused TAS. So that ruled out vancomycin. So after looking around the world for a better drug, I decided that Vigamox was probably the best. And every case since then, I've been using Vigamox, and the best dose is, I've decided 600 micrograms in 0.4 cc, so you can wash out the anterior chamber. We've done about 10,000 cases like that, and we've had no side effects of the drug and no infections at this dose. So interestingly enough, I go around the world and talk about bilateral surgery, and I thought that people weren't getting interested. But then recently I was involved in a webinar from Quebec City, which was in French, and the chairman of the department there, Marie-Ève Legaret, got up and said that, well, after I spoke to them in 2015 or so, in 2016, they began doing bilateral cataract surgery, and they rapidly went from 6% to 22%, and now to almost 60% of their cases when the patients are given a choice. And like everyone else in the world, they found their infection rate actually went down, and their complication rate went down. And they're now getting an infection rate of about 1 in 14,500, which is similar to what we showed with the International Society in reviewing 125,000 cases we did. But we weren't the first to do bilateral surgery. It turns out the first was Jacques Daviel, who in April the 8th, 1747, performed his first extracapsular surgery after finding out that couching didn't work very well. And he did the left eye first, which is what I do, but I don't do that because of him. It's just how our room is laid out. And by 1756, he'd done about 434 cases, and he deemed about 88.5% of these to be perfectly successful, which is extremely good considering the time. So we're all following in footsteps who've gone before us. We began our society, the International Society of Bilateral Cataract Surgeons, in 2008. Most of our members initially were from Spain. We had 2 from Britain, 1 Swede, 1 Canadian, and 1 South African, totaling 9. There are only 7 of us in the picture because 1 guy is taking the picture and 1 wasn't there. Our society has 1 rule, and the rule is that if you're doing bilateral surgery and you get an unresolved complication in the first eye, the second eye should be deferred. An unresolved complication is something like a broken capsule with a dropped nucleus. It doesn't mean that perhaps the capsular excess was errant, but you rescued it. That's not considered to be an unresolved complication. But we've also all discovered and believe firmly that the best time to operate on the second eye is just after gaining the experience of the first eye. And we think that's why we have such low complication rates and low infection rates, because the second eye of each patient is always much easier, because it's pretty much exactly the same as the first eye, and you know exactly what issues you might run into. We suggest that everybody follow these principles of safe surgery for bilateral surgery. We published this in 2009 after arguing back and forth in our society for a year. And it's become pretty much a global standard for how to do bilateral cataract surgery safely. It's available on the ISBCS website or the Eye Foundation of Canada website, or if anybody asks me, I'll send it to you. So I began to get involved in debates, and I thought that people would be angry about bilateral surgery. And then the ASCRS and ESCRS both invited me in the same year to a big debate in front of the whole audience. And I was quite surprised because in both of them, the opposition evaporated immediately. I had been to Colorado and spoken in front of Kent Syverson's group. He was my opposition for the first one. And I found out that by the time he came to the meeting, they had converted about 70% to doing bilateral cataract surgery. And instead of him opposing me, he just agreed with the idea that it's much better. Jose Guel in Spain was not doing bilateral surgery, but when he went through all the literature and his colleagues that were doing it and looked it up carefully, he found out that the only reason not to do bilateral surgery is that he felt that patients may trivialize ophthalmology and surgery if it looks so easy, which is not a good reason not to do something. And then I met this group that invited me to New York because they have a center there, and they were developing methods to do small incision cataract surgery in sub-Saharan Africa and parts of Asia, including some parts of India. And they wanted to do 1 million cataracts doing manual small incision cataract surgery with a kit they developed. And I went to New York and looked it over and talked to them. And they're a rather impressive group, but I really don't know how well they've done in their work since then. I do know that I've been asked to speak at the Manual Small Incision Society a couple of times with these webinars. And it's interesting, the excellent results that Indians particularly get with manual small incision cataract surgery. But I just thought I would suggest to you that the progression of cataract surgery really follows the same path in almost all countries. India, of course, was the first. Sushruta in about 500 BC was the first person or surgeon to do cataract surgery. And 2,000 years later, Jacques Daviel went to do extracapsular surgery instead of couching. And then 200 years later, we got IOLs when Ridley implanted them first with extracapsular cataract surgery. We then got a period of 25 years of intercapsular surgery, then back to extracaps and manual small incision surgery to implant lenses, and then 15 years later, phaco, and then 25 years later, femto. India is now on the bridge here between doing manual small incision surgery and phaco, with a few doing femto. But I suggest that as India's economy gets better, because India, I think, has an extremely good future economically, probably better than almost any country in the world. And I think he will progress the same way as the West has, and move more and more to phaco and then to femto, which will become cheaper over time, and perhaps we'll have new things. So I think you should be interested in the new things, because that's where you're going to be headed. I'm going to talk about the advantages of doing bilateral surgery. And my favorite one is that we can do people we wouldn't otherwise do. So I began to do amblyopic eyes in about 2000, when some patients came in and they would have a narrow angle or some almost not that greatly significant reason to consider doing their amblyopic eye. And then I found out after doing 50 or 100 of these people that they see surprisingly well. And when you correct the optics of amblyopic eyes with an intraocular lens, a lot of them a year later see 20/40, 20/50 really quite reasonably well. And so they're not so densely amblyopic and irretrievable as we had thought. So I do them all the time now, because they're lying there anyway, and they might as well have the second eye done, which they don't use. It's wonderful for uncooperative patients. All of these people volunteer to have their pictures. People that have psychiatric problems, Down syndromes and others, people that have like Duchenne dystrophy, where you can't move them from their chair very easily and take a long time to position. I do a lot of anesthesia class 4 patients, patients who aren't expected to live more than 5 or 6 months, but unfortunately have cataracts sometimes from their chemotherapy and would like to be able to at least read for the last 6 months of their life. They're extremely grateful, and they're very rewarding. And then you have people that are hard to position, which are also much easier to do both eyes at once than to do 2 different operations. My main suggestion is, if you do bilateral surgery, be careful. Don't take anything from the first to the second eye. Read over these suggestions we have for excellence. I personally make one of these handwritten charts and put it on the microscope for every case, so I know which person I'm doing, which eye I'm doing, which intraocular lens I want for that eye, and if I'm going to rotate it, the axis of astigmatism or whatever, if it's toric. And I make sure that when the circulating nurse hands the lens to the scrub nurse, she calls out which patient, which lens, which eye. The scrub nurse then announces the same thing as she gives it to me, and I look up at the microscope and make sure that it's in my handwriting, that I have checked which one I'm getting. And in doing that, I have yet to make a right to left error in 12,000 or so eyes. And make sure all of your staff are aware of how to do bilateral surgery before you start doing it. Next thing, I think it's critical to use intracameral antibiotics. There have been endless studies of over 10 million eyes showing how effective they are. They reduce the infection rates by a factor of about 4 or 5. And they cost very little. Even in the United States, it costs $20 per eye, which is by far the most expensive country in the world. In Canada, it costs about $1 or $2 per eye. In India, it probably costs still less. And you save patients from losing their vision, and it just makes your life a lot easier. Beware about myths opposing bilateral surgery. People will come to you and say, well, I don't do bilateral surgery because you might get bilateral postoperative endophthalmitis. Well, we found in our society and looking at the world literature that the only cases they have had of bilateral endophthalmitis have been in patients where there was no sterility protocol followed. There was a serious breach of sterility. But if you don't do that, if you follow our suggestions and use antibiotics, the real risk of getting bilateral endophthalmitis simultaneously is about 1 to 2 or 300 million, which means about 1 patient in the world every 10 or 20 years might get bilateral endophthalmitis, doing our 20 million cataracts per year around the world. And then there are all these arguments about improving the refractive result if you modify your IOL choice to the second eye. It turns out it's just not true. If you use ultrasound, it might be true. But if you use our new biometry instruments, IOL Master or LensStar, and you do topography to check the cornea, and you use one of our modern equations, it just never happens. And I haven't had to change a lens or do anything to correct anybody in the last 15 years. So it's not a reasonable worry. If you talk about bilateral surgery, please use the terminology that we've approved. And that's because I endlessly get articles to review and I can't understand what they're doing because they make up their own terminology. There are some quotes that I like, and one of them is from John Bolger, who had a course we gave at AIOS in 2008, basically reviewed the traffic accident mortality in London where he lives. And he said, when people are worried about the 1 in a million risk or less of getting bilateral endophthalmitis, he tells them that the risk of driving to the 3 extra visits in London from their home, when he judged about the average distance, how far they live, the risk of dying in a car accident is 3 times as high as the risk of getting bilateral endophthalmitis. The difference is that endophthalmitis you can treat. Death in a car accident you can't treat. And so he said you just balance your risks in life, but you always take some risk, but it's best to have it minimal. And Olivia Lee published an article in the AJO showing that the risk of bilateral endophthalmitis is about 1/2000th the risk of dying from general anesthesia. So it's not particularly high. People weren't doing it before because they, in many jurisdictions, were getting paid more to do both eyes separately. And now they want to do it because they find they're being reimbursed better by doing both eyes together. So COVID-19 is changing perceptions, but we hope it's not for the wrong reasons. The need to wait between cases is changing attitudes. And in many places, in many jurisdictions, you can do almost double the number of cases as bilateral surgery as unilateral surgery. And so numerous groups now are trying to go to their governments and to change the funding models to allow them to do bilateral surgery. So the rationale behind bilateral surgery really is that what we're doing is we're fixing the visual system at one sitting and not one peripheral receptor. It's better for the patient, it's better for the family, it's better for society, and the global risks of everything are a lot less in doing bilateral surgery rather than unilateral surgery. The documents for the ISBCS are now stored on the Eye Foundation of Canada. So you can either go to ISBCS or Eye Foundation of Canada and you can find anything you want. Bilateral surgery is increasing rapidly around the world, spurred by COVID-19. If you're going to do bilateral surgery, whether you do extracapsular surgery or you do phaco or femto, please follow the general principles of excellence, which are now accepted as a global standard. And the reasons that have been proposed not to do bilateral surgery simply have not been verifiable in any studies. The risk of endophthalmitis occurs only if you don't follow our principles and don't use antibiotics. And the need to adjust the second eye IOL power just never happens if you use modern instruments. The real issue is money, and COVID is changing our perceptions of what perhaps is best for the patient.